Hi, this is Dr. Steve Johnson presenting Pulmonary Anatomy and Restrictive Lung Dysfunction audio lecture for the Cardiopulmonary Physical Therapy curriculum as part of the UW-Milwaukee Physical Therapy program. The companion documents, which are found in D2L, is the PowerPoint presentation similar to what we will be going through today, as well as a outline notes study guide to assist you as you are following along with this presentation and in the assigned readings, which are Hilligus chapters 1 and chapters 2 as it relates to anatomy and physiology of the pulmonary system, and chapter 5, restrictive lung dysfunction. We'll go ahead and begin the lecture. The bony framework that makes up the thorax contains the sternum, the ribs, and the vertebral column, which is not pictured here. This bony framework serves as protection for the vital organs, as well as a contained system to create negative pressure when you include the diaphragm in the inferior portion of the thoracic cavity. The muscles of inspiration and expiration then act on the bony framework of the thorax in order to expand and contract the thoracic cavity as a way of moving air in and out of the lungs. On the left, we have the muscles of inspiration, primarily the external intercostals and the diaphragm. So in normal breathing, the external intercostals and the diaphragm serve as the muscles of inspiration. In addition, we have other muscles that can act as accessory muscles for lifting and separating the thoracic cavity. Those include the sternocleidomastoid and scalenes, as well as serratus anterior, and not pictured here, pec major and pec minor. You will note that patients who have pulmonary issues will often exhibit hypertrophy of the sternocleidomastoid and scalenes as a compensatory mechanism for breathing. Expiration is largely a passive activity and occurs without muscular action in normal tidal breathing. However, in times of increased demand, the internal intercostals, the rectus abdominis, transverse abdominis, as well as the internal and external obliques can assist with compression and decreasing the thoracic cavity. Now that we've discussed the basic bony framework of the thorax, as well as the muscles used with inspiration and expiration, we're now going to discuss the breathing mechanisms. First being the pump handle mechanism, where the ribs are lifted superiorly and anteriorly with the movement of the sternum as the sternum lifts up and outward away from the chest cavity with each breath, inhalation and exhalation, inhalation and exhalation. Very similar to a traditional pump handle. The second mechanism of breathing that occurs at the same time as the pump handle when viewed in a different plane is the bucket handle mechanism, which is the elevation and lateral shifting of the ribs. Similar to a bucket handle, which is attached anteriorly and posteriorly and swings up and away. With inspiration, the ribs are pulled up and away from the body. We talked about this during lab when we were doing observational analysis of patients, and the fact that some patients lose that 90-degree rib angle because of a condition known as being barrel chested. That's because they are hyperinflating and keeping their ribs in an elevated position for longer and longer periods of time. I'll now ask you to take a moment and watch a brief video with a 3D demonstration of bucket handle, pump handle, and diaphragmatic breathing. Following watching that video, we will resume the lecture. Okay, hopefully you've had a chance to take a few moments and watch the 3D demonstration of the mechanics of breathing. I think it helps to see the dramatization of the movement of the bones and muscles, uh, which help with breathing. The mechanism of breathing is a method to move air in and out of the lungs. And so an understanding of the various volumes and capacities in air exchange help with understanding pathological conditions. We're going to go over each of these in detail, and we'll review them again in the lecture portion of the course. The first is the tidal volume, or resting breathing, which is the traditional breathing in and out, which many of you are probably doing right now as you're listening to this lecture. When you take a deep breath in, that represents inspiratory reserve volume. When you exhale as far as you can, that additional expiration represents expiratory reserve volume. The final volume that we're going to discuss is what's referred to as residual volume. That is the air that is left in the lungs after you have exhaled all the air that you can voluntarily. There is still what's referred to as a physiological dead space of air that remains in the lungs. So again, as review, you have tidal volume, inspiratory reserve volume, and expiratory reserve volume. The final volume is residual volume, which is the air that's left in the lungs following exhalation of the maximum amount of air voluntarily. Those various volumes are combined for discussions of various pathological conditions, as well as comparing people to normative values. The first such capacity is referred to as total lung capacity, and the term total lung capacity defines what volumes contribute to total lung capacity, all of them. Residual volume, expiratory reserve volume, tidal volume, and inspiratory reserve volume. So that is all the air that can possibly be contained in the lungs, is total lung capacity. The second capacity that we're going to discuss is vital capacity. Vital capacity is essentially the same as total lung capacity minus that dead airspace known as residual volume. So vital capacity is the amount of expiratory reserve, tidal volume, and inspiratory reserve. Pardon me. Moving to a different slide, which represents the same volumes and capacities, we'll discuss the additional two capacities, inspiratory capacity and functional residual capacity. Inspiratory capacity is the inspiratory reserve volume and the tidal volume, while functional residual capacity is the expiratory reserve volume and the residual volume. These various capacities and lung volumes come into play when we start to discuss the various pathologies of the pulmonary system. We're now ready to begin talking about Chapter 5 and pulmonary pathology The first type of pulmonary pathology is referred to as restrictive, and this is defined as where the volume of air is reduced, while obstructive pulmonary pathologies are defined as a condition where air exchange is impeded. Many of the conditions that we're going to discuss may actually have some restrictive and obstructive aspects to them, but from a definition standpoint, they are categorized into either restrictive or obstructive categories as the primary causation for pulmonary dysfunction. Restrictive lung dysfunction will be the focus of this presentation, and obstructive dysfunction will be the focus of the next presentation. Restrictive lung dysfunction is defined as an abnormal reduction in the pulmonary ventilation where lung expansion is diminished. This is a condition. It's the result of some other disease process. It is not considered a disease itself. This is an important distinction that we're going to go through a whole laundry list of pathologies that then result in restrictive lung dysfunction. So you need to think of this as this is the result of many other disease states, some that you probably could think of, and some that you'll be surprised as we go through this lecture. I've always liked this particular slide as a visual means, myself being somewhat of a visual learner, looking at what we were just talking about related to lung capacities and lung volumes. So we have our tidal volume, we have our inspiratory reserve volume, we have our expiratory reserve volume, and we have our and now I draw a blank. Our residual volume. My apologies. With a restricted lung, you see that there can be a decrease in all of these particular areas. So you have decreased ability to take a deep breath. You sometimes see a decreased ability for just normal tidal breathing, as well as expiration and residual volume. Obviously, if all of these volumes are being decreased, you're going to see a potential for decrease in many of the combination capacities, vital capacity, inspiratory, and functional residual. I think the large takeaway from this slide is picturing that lung being the artist's rendering of this lung, that it is smaller in terms of the amount of air that can fit into that lung in all of the categories compared to what would be considered a normal lung. And then obviously another visual representation of the various volumes and capacities. We're now going to discuss the pathophysiology of restrictive lung dysfunction. There are three main factors that contribute to restrictive lung dysfunction: compliance, lung volumes, and work of breathing. Compliance. The loss of expansion in the lung tissue or chest wall results in increased resistance to lung volume expansion. I think this is very obvious, and we will discuss many conditions that can impede or cause a decrease in the ability of the tissues to be flexible and stretchy enough to allow full expansion of the chest wall. One such condition that we're going to be discussing is the normal aging process. So no disease state, but just aging in and of itself causes an eventual loss of compliance in tissues, resulting in restricted ability to expand the lungs. Obviously, the lungs themselves having a decreased volume will result in restrictive lung dysfunction. There are many conditions where there is damage to an area or portion of the lung, or the entire lung itself never formed in gestation, or some sort of disease state required removal of that lung, or some sort of insult damaged the lung tissue. And finally, there's the work of breathing. Normally, breathing is a passive activity, and with restrictive lung dysfunction, you see an increase in the amount of work the body has to do to breathe, and this becomes extremely energy consuming. This significant energy expenditure will progress as the disease state progresses. So the work of breathing and the amount of lung dysfunction will progress as the various disease states that we discuss progress. An interesting statistic from the Hillegas reading is that 5% of energy is used in normal breathing. So 5% of the oxygen that you breathe in is typically devoted to the act of taking in that air itself. So a fairly efficient method of bringing in oxygen in order to create energy. The work of breathing in people who have restrictive lung dysfunction, this can increase to up to 25% of the oxygen taken in is used for the work of breathing itself. This becomes very cyclical in nature. If you're using all of your energy to breathe, you don't have energy to do other activities, and can become a severely limiting situation. One last comment before we leave this slide. When lung volumes are being analyzed using spirometric measurement, total lung capacity and vital capacity are two of the most commonly measured capacities when assessing patients with restrictive lung dysfunction. So what are some of the signs and classic symptoms of restrictive lung dysfunction? Some of the classic signs include tachypnea, which is that increased rapid breathing rate, hypoxemia, where low oxygen saturations at rest or with activity, depending again on the progression of the condition. Decreased breath sounds, sometimes what's referred to as dry inspiratory rales. Because of alveolar atelectic action, you can hear this typically in the base of the lungs. We discussed this in the auscultation lab earlier this semester. You will see decreased lung volume and capacity, which we just discussed in the previous slide. You will see decreased diffusing capacity of carbon dioxide. This is significant. As much as a 50% reduction in perfusion of carbon monoxide from age-related predictions can occur in patients with restrictive lung dysfunction. And finally, as restrictive lung dysfunction progresses, cor pulmonale, right-sided congestive heart failure, which we discussed in the previous unit with Professor Kittleson, can result from prolonged periods of restrictive lung dysfunction, which will in and of itself create circulatory and health issues. Some classic symptoms of restrictive lung dysfunction include dyspnea, so observable shortness of breath, cough, typically referred to as an irritating, dry, non-productive cough, and finally, the third classic symptom of restrictive lung dysfunction is excessive weight loss and muscle wasting. Some of the estimates from your reading related to Hillegas is that there's a 12-fold increase in energy expenditure to breathe. This has been analyzed, an analogy has been made that this is the equivalent of having to run a marathon, energy expenditure for having to run a marathon 24 hours a day, 7 days a week. Unfortunately, having worked with patients with restrictive lung dysfunction, what you start to observe is that many of these folks sadly can't take the time to eat, and eating becomes difficult because it takes time away from breathing, which has a dual influence on the weight loss and muscle wasting. They can't consume enough calories to keep up with the calories they're burning just to breathe, combined with the fact that stopping to eat gets in the way of consumption of food. And so here's a classic picture of a patient with restrictive lung dysfunction. You can see the significant wasting, as well as you can see the scalenes in the sternocleidomastoid hypertrophy, uh, as well, that we talked about a few slides ago. Okay, moving on. We're now ready to talk about what are some of the conditions, disease states that can cause restrictive lung dysfunction. Again, as I had stated earlier, there's literally a laundry list of restrictive lung dysfunction causative factors. This list includes developmental and maturational causes, pulmonary causes, cardiovascular, neuromuscular, musculoskeletal, connective tissue, immunological, pregnancy, nutritional/metabolic, traumatic, therapeutic, pharmaceutical, and radiologic. Again, this course is not intended to be a pathology course, but we will discuss many of these conditions very briefly and point out to you the causative factor related to each of these conditions that results in restrictive lung dysfunction. So the first category is developmental or maturational causes of restrictive lung dysfunction. Obviously, there are conditions where infants are born with abnormal fetal lung development. This could be agenesis, or a total absence of the parenchyma and or bronchus, aplasia, a rudimentary bronchus but no parenchyma, or hypoplasia, a rudimentary bronchus and reduced parenchyma. The important part to understand here, I don't plan to test you, and I don't think anyone plans to test you related to the various forms of abnormal fetal lung development, but understanding that there are children born with a restricted lung capacity because of poor development. So children that are born with abnormal fetal lung development obviously have severe pulmonary insufficiency that is commensurate with the amount of lung tissue that did not develop. They could be asymptomatic if the amount of lung tissue that did not develop is small, or they could be severely cyanotic. And so ultimately, it is based on how much of the lung tissue did not develop that determines the severity of restrictive lung dysfunction. Another category is respiratory distress syndrome, which is also known as hyaline membrane disease, and is a factor with premature infants. We'll discuss that in more extensive in the next slide. And then, as I had spoken earlier, normal aging changes the way that the lungs function due to loss of compliance, as well as a topic that we're going to discuss, which is called closing volume. Premature infants can develop hyaline membrane disease because of a lack of development. This is seen primarily in infants with less than 36 weeks gestational age. The statistics are that RDS will develop in preemies 75% of the time if they're born at 26 to 28 weeks gestation, whereas a baby born 36 weeks or after only has a 5% chance of developing hyaline membrane disease or respiratory distress syndrome. The primary risk group from an epidemiological perspective are premature white males who have been born to a mother that has diabetes. What happens is the underdeveloped lung tissue does not have the ability to create enough surfactant. Surfactant is a soapy, oily substance that keeps the alveoli puffed open by creating surface tension so that the alveolar sacs look like little bunches of grapes. With a lack of surfactant, the tissue wants to pull together and stick to itself, and so you get something that looks like a clump of raisins rather than these nice grape-looking alveoli. Another issue is that many of these infants have to be assisted with breathing, and so they end up being mechanically ventilated. And again, picturing mechanical ventilation is forcing air into these tissues rather than the air passively moving into the tissues. And this can also affect hyaline membrane formation and can result in pulmonary edema from these very, very fragile tissues being forcibly aerated with mechanical ventilation. In addition, pulmonary hypertension can result, and the resultant hypoxemia can and acidotic changes can trigger vasoconstriction in the infant. The condition known as ductus arteriosus, which creates increased blood flow fluid pressures, can complicate this situation and resulting in ventilation perfusion mismatching. And so again, premature infants lacking adequate surfactant and having to be mechanically ventilated. That mechanical ventilation then causing some tissue damage can result in hyaline membrane disease or respiratory distress syndrome. So what are some things that can be done about this? Pardon me. One treatment is to give preemies an aerosolized surfactant, which helps keep their lungs open and hopefully avoiding mechanical ventilation. And birth mothers being given pre-birth corticosteroid injections to speed along development of fetal lung tissue prior to birth. Going back one slide to now talk about some of the issues with normal aging. As we discussed earlier in the lecture, normal aging in and of itself can result in restrictive lung dysfunction. You see a decrease in compliance of roughly 20% between the ages of 20 and age 40. An individual's maximum voluntary ventilation decreases 30% between the ages of 30 and 70, and vital capacity decreases by 25%. With aging adults, we see changes in bony and cartilaginous flexibility, which restrict expansion and limiting of airspace increase. This lack of flexibility also will increase what's referred to as that physiological dead space. So total lung capacity may not change if we go back a couple of slides, in that aging adult, the total lung capacity may not change. However, what we may see is an increase in that residual volume, which will obviously steal volume from what's referred to as the vital capacity. And really, the vital capacity is what's important in terms of ability to oxygenate and also to shed carbon dioxide. So again, in the normal aging adult, that lack of flexibility will start to cause that physiological dead space, that residual volume to grow and decrease vital capacity. Along with aging, we see a concept known as closing volume. Closing volume is the concept of at what point does the air stop freely leaving the lungs, related to passive air exchange with expiration. By age 55, the small airways have closed at or above the functional residual capacity in a supine position. So again, that FRC is the threshold right at which your tidal volume is occurring. So at age 55, when a person is laying in a supine position, they're starting to see small airways closing off right at the threshold of their tidal volume. By age 70, those small airways are starting to close off even in an upright position. This is where that concept of work of breathing and energy expenditure that the person then has to work in order to take air into and out of their lungs. This is obviously influenced by things like smoking, and the presence of an endotracheal tube can also trigger changes in closing volume. We'll back up here just for a second. One encouraging statistic is that there is some hope for elderly sedentary individuals and people that are starting to suffer the effects of restrictive lung dysfunction due to normal aging. Studies have shown that individuals who take up regular exercise can improve their oxygen uptake by 5 to 25% and achieve a physical performance level 5 to 10 years that they had been able to perform 5 to 10 years previously. So again, part of the encouragement for seniors to stay active, to remain flexible, to perform resistive exercises as well as aerobic exercise, is to stave off some of the effects of this normal aging process that makes restrictive lung dysfunction limit their oxygen capacity. This will conclude part 1 of the restrictive lung dysfunction lecture. I'm going to save this lecture in parts because of the length of the lecture and the size of the files being created. So I'm going to conclude the lecture at this point for part 1. We will resume part 2 of this lecture, talking about some additional pulmonary causes of restrictive lung dysfunction.